I've been asked to tell my story about what occurred to myself following opioid tapering about 2.5 years ago. Just to give a little bit of background or context, at the time I was using a slow-release Palexia dose of 100 milligrams twice a day, or 200 milligrams in total. Not a particularly high dose, but it was decided at the time that I'd trial doing a 25% reduction. This was in mid-2009. Despite the fact that I hadn't displayed any behaviours of opioid use disorder or addictive issues, this trial was agreed to, and I suffered terrible side effects. I developed a condition known as PAWS, or PAWS, Post-Acute Withdrawal Syndrome, which is a protracted withdrawal phase. I was told I'd be uncomfortable for a few days, but what occurred was somewhat of a nightmare because this lasted for 2 to 2.5 years. And it's only recently in the last few months I've had the clarity of mind again and some ability to do the things that I enjoy doing again. One of the things that did happen during this post-acute withdrawal syndrome phase was severe insomnia within a couple of days of being reduced. Later on, I developed high blood pressure, which I'm still recovering from. I had difficulty concentrating, anxiety, depression, fatigue, plus, and shocking headaches for most of this time, and I stayed at home. This actually had the opposite effect that it was hoping to achieve. I've actually read some recent research in Australia, which I note is of poor quality. They used 290 people in their sample group to self-report what had happened to them upon reducing their opioids. Yet I'm aware of American studies with 113,000 people in these studies who afterwards, the researchers showed that there were actually increased rates of overdose, withdrawal, and mental crisis up to 2 years. Very similar to the situation that occurred to me. And I don't believe it's a rare situation either. So my question to doctors is, how do you distinguish between drug-seeking behaviour and that of a chronic pain patient requesting temporary additional pain relief? If a patient is stable on their dose for years, hasn't had any particular side effects, or they aren't as bad as tapering, why should we not be allowed to continue legacy patients on the dose that we're used to, that has served us so well, and not be put into a situation where the pain and negative consequences far outweigh tapering?